a little bit of an overview of the format of this panel session, just to help you with knowing what to expect and expectations generally. I know that there are going to be many questions that you have, so we're going to have plenty of time for audience interaction and questions from the audience. We have 4 speakers today, and they are each going to be speaking for a maximum of 7 minutes, and we have a timer at the front, so we'll be trying to keep on time. And after all 4 have spoken, we will then have hopefully up to 30 minutes for some questions from the audience. So no direct questions, save them, and we have these mics in front of you, and I think you press the button, and when it goes red, it's your turn to speak. I'll be moderating the Q&A session and try and make sure that lots of people get the opportunity to ask the questions that they have. So, I'm going to very briefly introduce our 4 speakers. You should have their bios in front of you, so I'm not going to go into detail. But if you, I'll briefly introduce them, and please, the speakers, as I introduce you, come and sit up at the front in the seats. So we have Dr. Caroline MacCallum, who's an internal medicine specialist. Come up, Caroline, and Caroline's going to be speaking first. We have Dr. Sana-Ara Ahmed from the Ahmed Institute for Pain and Cannabinoid Research. We have Dr. M.J. Lloyd from the BC Centre for Substitution. And we have Igor Kovalchuk from the University of Lethbridge. So our first speaker will be Caroline.
Can you all hear me? Okay, this is my first 5 to 7 minute talk I've ever given, so let's hope this goes well. I know I've got some timekeepers here to keep me on track. So the title that I'm going to be presenting today, Cannabis for Deprescribing and Safe Dosing. Before I go further, I'm trying to get a bigger following on Twitter. I want to spread the word on cannabis and safe prescribing and provide some good evidence. So please follow me if you're on Twitter. Some disclosure before I get started. I do some consulting work and work with a number of different groups. Some are for research, some are cannabis growers, some are technology companies and pharmacies. So again, trying to really help move good information forward. And I was not paid to speak today. And some biases. I've done my best to stick to cannabis, THC, CBD, those sorts of words, and not using branding or cannabis company names. And I'm just going to apologize in advance because my titles, I can see the font is a little bit off. I think it just messed with the conversion from my computer, so I apologize. So why should we talk about cannabis as a tool for prescribing? So for those of you who may not have pain or chronic disease, what would that feel like? So there's many different symptoms depending on the disease, but overall, a lot of patients with chronic disease, especially pain, feel more than just pain or the symptom that is characterized by their disease, such as for Crohn's, they may have GI side effects. They also have trouble with their appetite, with anxiety, with depression, with sleep, energy levels, and many others. You can see from this graph the percentage likelihood of those symptoms. So we're treating a patient as a whole with all these symptoms and their conditions, not just one individual symptom or disease. And so cannabis actually is more than just a pain medicine or an anti-nauseant or something that can be potentially used for seizures. It can work for many different conditions and symptoms. And if we break it down by THC and CBD, 2 of the major players, we can start to see what the difference in terms of potential uses for these molecules. But there are over 140 other cannabinoids and many terpenes in the plant, which also provide medical value that we're still just uncovering every day. So not to say that this is just the tip of the iceberg. And so cannabis, I call it a multitasker. I like that it can work on so many different pathways, receptors, and I think that this is really different than a pharmaceutical drug because typically those are designed to work on one receptor to do one function. But here you can see cannabis is promiscuous. It's working on sodium channels, potentially NMDA, calcium, serotonin, and others. And up in the top left corner, I've actually added in a couple more based on the evidence that's evolving every day, really. We're seeing potential for it to function on glial cell health, as well as this endocannabinoid tone and the underlying physiology. So my patients say to me, especially those who have been on opioids before they start to use cannabis, that the things that they've noticed cannabis can be helpful for is to improve their symptom clusters, to improve their function, and to decrease their overall opioid use and their side effects from tapering down on opioids, as well as other pharmaceuticals that they're using. And this graph, I think, shows that well. This is from Dr. Zach Walsh and Dr. Lucas survey data looking at why patients use cannabis, and they do use it to substitute prescription medications such as benzodiazepines, antidepressants, anti-anxieties, and opioids. And so again, this is from 250 patients, and about 30% are using it to substitute opioids. So again, this is consistent with what I've seen in my clinic. And so I wrote this paper with Dr. Ethan Russo to really start to get how we can use this as a medicine. That was kind of the goal of this. So to really look at cannabis as a medicine, let's talk about doses, delivery routes, safety issues, and practical considerations for titrating. So these are questions that I usually ask myself before I decide if we're going to use cannabis in a particular situation. I won't go through all of them today because that's not really the point, but just to say that it may not be appropriate for everyone, and we just need to make sure our patients are on the right page with us and that our expectations are aligned, because there really isn't a cure when we're talking about something like pain, but to make sure that they understand what are reasonable outcomes. So this would be a typical approach I would use with a patient, just to give you some high-level thoughts. And this, again, comes from my paper, which you can download. It's open access. It's also on my website if you'd like to read it later. And just to back up, it was actually written for patients and physicians, so it's not meant to be super scientific, but again, to be a practical tool. So first of all, is the symptom during the day or in the nighttime? That would dictate, how much THC or CBD you may use and when and how you may use those. And what kind of symptom? Is it acute, meaning vaporization? If it's chronic and lasts 24 hours a day, a long-acting oil makes more sense because it's going to give you better coverage. So I try to use the analogy of insulin, which some patients need to use a long-acting, and then they use a short-acting with it in between. So I think that's a great analogy. And then also, what kind of condition is it? Is it inflammatory in nature? Is it neuropathic? That dictates, it doesn't dictate necessarily, but it gives you a hint as to what potential compounds are going to be more helpful. So I definitely use lots of CBD, but sometimes I have a good sense that it's probably not going to be enough depending on the condition, so consider that. And sorry, just 2 points at the bottom of that slide. Be careful with seizures and with psychosis bipolar. Even though you would think they're neurological, they really don't respond as well to THC. I can see I only have 1 minute left, so I'm just going to hurry up a bit. So there's lots of dosing in the article that I wrote, and you can get more of some of these forms and different tools that I mentioned on my website. So how can we make cannabis safer with opioid use? Sorry, I really not managed that time very well. But basically, I'll provide the slides that you can read future. But here's a lot of different physiology out there, publications on how we think cannabis and opioids are interacting. We know that cannabis can reduce the potential risk of harm with opioids because it is safer based on the therapeutic index you can see here. And basically, I believe that all patients who are on more than 50 morphine equivalent dosing should be considered for cannabis because I do believe that it reduces their risk of harm. And we actually know from the publications in 2017 on opioid guidelines trying to make things safer in the US and Canada, that once we hit 90 milligram morphine equivalent dosing, we actually start to see that the overdoses increase tenfold. And so there's 2 studies that I'm working on currently with a number of other brilliant researchers. This one in particular ranked first from the CIHR, the recent Catalyst grant, 2018. And this is the research needed in virgin areas, priority areas for cannabis. And Dr. Bill Honer and Dr. Will Knicker, our team leads, as well as Dr. Alistair Bar, and others. And we're looking in the downtown East Side hotel population and looking to see how legalization of cannabis pre and post legalization, how that population changes with regards to their mental health outcomes. And we hope that this will inform future studies, especially looking at interventional studies, which would be a benefit for sure. And then lastly, in my clinic, along with the same team, I forgot Dr. Knink on this one, but we're looking at using cannabis to reduce opioids in patients day-to-day using a natural study structure. And again, we want to use heart rate variability and other tools to assess somebody's withdrawal and see how we can taper taper their opioids, and using cannabis as best as possible to make it as smooth the transition as possible. So in summary, there's evidence for cannabis being used for opioid sparing. Cannabis makes opioids safer. It also makes opioids more effective. It also doesn't increase opioid blood levels, and it can help treat symptoms of opioid withdrawal, as well as many other things, and potentially improve retention in naltrexone treatment rehab programs. Thank you.
Thank you very much, Caroline. Okay, I'd like to welcome Dr. Sana-Ara Ahmed.
Hi, everybody. My friend Caroline did an awesome job talking about cannabis and an introduction to this, and thank you so much, Caroline. So, myself, I had a very organic introduction into cannabis, no pun intended. And myself, I'm an anesthesiologist, and my interest particularly is in interventional pain management. And the challenge as an anesthesiologist has always been that we're expected to manage the pain with opioids and other medications, and then hopefully also perform procedures to be able to alleviate the pain. Unfortunately, majority of the time, the patients that we do see are symptomatic of sleep disorders, they're symptomatic of anxiety disorders, and they're symptomatic of various other ailments, such as GI upset, migraine headaches, fibromyalgia, on top of their actual nerve potential pain. And I have been thinking long and hard about how to solve this issue in my practice, and cannabis became a very interesting modality that I could introduce into my practice. And I know that this is a conversation about genomes and how different populations function and exactly what we need to be understanding. And what I've learned in the last 5 years of my practice is that despite the fact that we have a lot of products available here in Canada, each patient does need a physician to guide them when it comes to managing their pain, when it comes to managing their anxiety, and when it comes to managing their insomnia. And the biggest challenge I think we do face, as Dr. MacCallum identified, is that we're facing an opioid crisis. And when we as physicians are guiding our patients, we're in so much need of evidence, and we're in so much need of data. And I was just wondering, in this room, how many physicians are here? I'm just curious to know. Wonderful. And any other health providers, nurses, RTs, physiotherapists, chiropractors, and then I guess mostly scientists and academics? Yeah? So clinically, the biggest challenge I think that we have is that we as a group of individuals who are keen on prescribing medical cannabis, we are often put off to the side because we're considered to be these fringe physicians who are very keen on prescribing something that could potentially be very unsafe. And Dr. Caroline did a really great job describing to you how it actually is much safer to be prescribing cannabis in the context of opioids. And for my particular interest, I have an interest in women's health. I have an interest in migraine headache management. And what led to me understanding more how the individual needs are required is that most of the time, women who are misunderstood when it comes to pain management are on multiple medications. And through the research that I have done, through the various publications that are available to us, it's very clear that you can de-prescribe a patient by using medical cannabis. However, how do you do that? And I think that challenge is what we actually are facing right now. We can take the literature, but translating it into practice is the challenge. And for myself in the last year or so, what I discovered is that cannabis, although it's an excellent modality for helping manage pain, as well as managing anxiety and insomnia, that are side effects of pain, there is a need for me to also particularly perform interventional pain procedures to to be able to target the pain particularly. But the challenge is, how do I know where to target the pain procedure? And cannabis has been that adjunct that has helped me open up and understand by speaking to my patients, because they're able to better explain to me what is going on. So case examples that I have had in my practice, I presented in Denver at the American Academy of Pain Medicine earlier on this year, presented this in New York as well. And it's because my colleagues in anesthesiology are probably the most, I guess you could say, hesitant to incorporate cannabis into their practice, because we are the Western medicine physicians, we are the physiologists in the operating room, and cannabinoids are not something that we've been taught. So we're fine with opioids, we're fine with gabapentinoids, we're fine with everything else. But cannabis, please don't talk to us about that. So what I discovered in my practice is that women who are experiencing pain, particularly when it comes to nerve pain in the pelvic region, they're unable to articulate exactly what their problems are. And in this instance, by using cannabis as an adjunct to be able to alleviate their sleep symptoms that they're having, as well as by being able to reduce their anxiety that they're having during the day, they were better able to articulate after 3 months their actual experience of pain. And through this understanding, I was able to do a targeted nerve block in the pelvic region, specifically an ilioinguinal nerve block that was ultrasound guided, which helped me understand that there was actually missed cases of pain that were occurring. And this series I presented, so the first patient actually was an undiagnosed endometriosis. She was 18 years old when she was first diagnosed with fibromyalgia, and she had had pain management for the last 20 years. And when I saw her, I understood that after having treated her with cannabis and having her come off of many of the medications that she was on, that were creating a brain fog and not allowing her to articulate to her family physician what the actual problem was, we finally came to understand that she actually had endometriosis. A referral to the surgeon then resulted in her having actually a hysterectomy, and now she doesn't require half the medications that she was requiring before. So this really interested me because it helped me understand that there was a new way of approaching pain. This didn't necessarily have to be the way everyone else is doing it. The second case that came up in my practice, unfortunately, this young woman, endometriosis, chronic pelvic pain, goes to emerge all the time, having lots of pain problems, getting a shot of morphine every time she goes, was a missed kidney stone. She had kidney stones for the last 3 years, but was always being sent home under the impression that she just had her chronic pelvic pain. And the physicians that were seeing her in the emergency room were not receptive to this because she was anxious, she had a diagnosis of fibromyalgia, she had a diagnosis of chronic pelvic pain, a diagnosis of bladder interstitial cystitis, and due to this, she was misunderstood. And last but not least, my last patient that I presented was a lady who also had a hysterectomy due to endometriosis, but was on so many medications that she had become a very altered personality. And it didn't make sense to me because I had a very different rapport with her in comparison to what her family physician had said. And in that time period, by being able to identify the source of her pain and producing results that were positive by doing nerve blocks, I actually was able to reduce her initial cannabis use. So to clarify, she was already using cannabis, but didn't know how to use it. So by introducing CBD into her particular care, I was able to identify that her particular needs were not necessarily to be high THC. And I guess what this poses a question to this entire forum is that we have a female plant that is very beneficial to women, and we don't necessarily know exactly how to use it. We understand on a high level theoretically that there is a need for us to be able to use it when it comes to opioid sparing and when it comes to using it as a deprescribing model. However, how best do we use it to incorporate in improving the quality of life of women who are not necessarily requiring it just as a medicine, but as a quality of life indicator when it comes to actually targeting their pain? So I'm going to leave that question up to the audience, and I appreciate you so much for your time. Thank you.
Okay, moving on.
Thank you very much, Ellie, for the introduction. Thank you, Genomics, for the opportunity to present today. I'm just looking at my slides.
Yep, just push next.
Okay. Oh, where's the next one? There we go. My name is Ahmed, I'm a research scientist at the BC Centre on Substance Use and an epidemiologist. And I hope that the talk that I'll give today very briefly about some of the work that we have been doing around the overdose crisis and cannabis is only interesting, but I think hopefully draw important parallels with the great two talks that have preceded me about clinical and individual level experiences of cannabis. Before I get there, I want to share some of my disclosures. I'm supported by the U.S. National Institutes of Health, CIHR, and Michael Smith. And since January 1st, I've been UBC's inaugural Canopy Growth Professor in Cannabis Science, which was a position created by arm's length gift to the university by Canopy Growth, licensed producer of cannabis in the BC government's Ministry of Mental Health and Addictions. And so if you're playing along in the audience, you can see that yes, I'm supported not only by Donald Trump, but the world's largest producer. So that's another thing I would never expected my career to do. And I also want to start by respectfully acknowledging the land on which I live and work as the unceded territories of the Coast Salish, including the Musqueam, Tsleil-Waututh, and Squamish peoples. I'm sure we all don't need to know that we are in the midst of a public health crisis. This figure was published in Science late last year, showing the terrible exponential growth in accidental drug overdoses throughout much of Canada and the United States beginning in 1980. There are many causes for this crisis, including the poor regulation of very powerful opioid analgesics, the contamination of our drug supply with fentanyl and other novel opioids, as well as the continued use of prohibition and other forms of drug control. It's important to note from this not only that we are seeing unprecedented numbers of deaths here in British Columbia and around Canada and the United States, but also this is largely being driven by fentanyl. There are good clinical and public health interventions to reduce or even eliminate the risk of drug overdose. The problem is, for many people at the highest risk of overdose, these interventions, including methadone and safe injection sites, are simply not available to them when they need them most. So there clearly is need for more, better, and new interventions, especially around the experience of pain and the management of pain, especially for people who use drugs. Beginning in 2014, we began to see very interesting and preliminary research showing differences in U.S. states between states that had and had not legalized medical cannabis. In 2014, the first paper, the bar there on the right, showed that in a longitudinal analysis, states that had some form of legal access to medical cannabis had approximately 25% lower rates of opioid analgesic mortality than states that did not have any form of illicit access to medical cannabis. In follow-up studies, and those are the first three bars, researchers demonstrated that there's differences between medical and non-medical cannabis and non-medical cannabis states also extended to lower levels of opioid-related hospitalizations, lower numbers of opioid doses, and lower numbers of opioid prescriptions associated with having a legal medical cannabis system. So what's happening here? I'm fortunate that my two previous presenters have really done a very good job of showing and demonstrating some of the very important interactions between opioids and cannabinoids on the individual in a clinical setting, especially for individuals with chronic pain. As an epidemiologist, I might suggest that what we might be seeing in these findings is evidence of drug substitution. That is, individuals substituting a lower risk drug, or cannabis, for a higher risk drug like opioids. As Dr. MacCallum mentioned, there is believed to be no effective fatal dose of cannabinoids. There's never been a case report of a fatal overdose strictly from cannabinoids, and I think the continued health and prosperity of Willie Nelson probably suggests that we go ahead and find a fatal dose of cannabis. Now, when I present these sort of findings, many people say, well, this is very silly for us to be suggesting that we should be replacing cannabis, replacing opioids with cannabis, but that is in fact drug substitution and harm reduction are two very well-established principles in public health and in drug treatment. What we have done in my group over the last number of years has tried to investigate these preliminary findings using individual level data from 3 prospective cohorts of people who use drugs here in Vancouver and the downtown east side. And in longitudinal analysis among over 3,000 people at the highest risk of overdose here in Vancouver, we found that frequent daily cannabis use was correlated, associated with several benefits, including lower rates of the initiation of injection drug use. And injecting drugs is one of the most important risk factors for overdose. We also found in a study published last year that people using cannabis were more likely to be better retained on opioid agonist therapy compared to individuals who were not using cannabis. In a urine drug screen paper, we also found that individuals with evidence of THC in their urine had far less likelihood of evidence of fentanyl exposure in their urine. And we also found that there are small groups of individuals in our studies who are intentionally using cannabis as a harm reduction intervention. And in one case, we demonstrated this preceded significant declines in the frequency of crack cocaine use. So I'm reaching the end of my time, so I do want to emphasize that these are preliminary findings. These are largely correlations. They are supported by important preclinical research, but they remain simply observational findings. We cannot conclude that there's a causal mechanism at work here. And for that reason, we are planning controlled trials to try to determine if these benefits are further seen in experimental trials. And to see indeed if through the controlled administration of cannabis, we can indeed reduce the risk of overdose for these individuals at highest risk of overdose. Through these trials, we will also hope to learn what the risks and safety harms of this approach might be, which is very important for individuals who are choosing to use cannabis in an attempt to reduce their opioid use and their opioid risk. And as Dr. MacCallum has shown, there really is no such thing as cannabis. It is a very broad class of chemicals, and so hopefully through our studies we will also be able to test different cannabis use dosing strategies to understand for people at the highest risk of overdose what the role of cannabis might be in their health and well-being. Thank you.
Alright, morning guys. I'm probably more of a caser, so forgive me. Alright, so I'll present two parts of work what we've done. One describing the individual use of variety of strains on cancer, and second, I'll present the algorithm that allows you to select the best line for a specific condition. Well, what we've done in the lab, we've used several hundred strains of marijuana and cannabis, and we created hybrids. So we use solvent-based extraction from flowers, right? So then from this, we dry it out and then basically use to treat different cells. So in this case, we have profiled at the stage we've done only all 300 already, but here we profiled about 177 extracts of various different strains. Agnostically, we don't initially analyze terps or cannabinoids in those extracts. And we've done a variety of tests for proliferation and identified 9 best cancer lines that have been patented. So here is just to give you an idea or a glimpse of triple negative breast cancer. So you see one of the lines clearly inhibits the growth, whereas others have no effect. And just to give you an idea, 4 different extracts. So this one is a dose-dependent inhibition versus the others are not. So obviously we have data on a number of different normal cell lines that does not inhibit their growth, right? And to demonstrate you that not only different cannabis strain has different effects, different type of cancer would be differently affected. So if you compare this to those nodules that knowledge cell lines, one the triple negative, this one is positive by the receptors present in the breast, basically cells. So this cancers are very different, so require different therapy, right? And just give you one example, the line that is very effective, dose dependence has much lower effectiveness on a different cancer line, and about 50% extra that work on this cancer cell line would not work on this one, right? So that would tell you that individually there would be very different response to the same cannabis. When we've done the correlation for breast cancer, correlation from about 170 different strains, and colon cancer we've done about 50. There is no much of correlation for THC, CBD for breast cancer. For colon cancer, there is a positive correlation for THC and negative for CBD. What about terps? Opposite picture. So if you see breast cancer, there is a bit of correlation for the total terps and negative correlation, and specifically negative correlation for alpha-pinene for them. For colon cancer, it's opposite, right? So we have data for over 8 different cancers, and different terps, different profiles would have a different correlation. What does it tell you? Well, different strains would have different effect on different people, right? So there's, I agree with previous speakers, there's no such thing as cannabis medicine, so it's very, very specific, right? So now, well, I'm sure all of you know major CB1, CB2 receptors. So one is mostly in nervous system. Second one is mainly in the immune organs, so in the blood, for example, intestine. They do work in similar way. The phytocannabinoids work very similar way on your endocannabinoids. So we have chemicals that work on those receptors. And we have many receptors that potentially cannabinoids work on, and we may not know all of them. We do not know all of them. And what we've done in the lab, we have profiled the data that are available publicly, let's say for expression of CB1 and CB2 receptors in control samples and multiple sclerosis, and we just made a correlation, let's say for CB1, so you see a nice correlation for both, for example, right? But if you look at CB2, the correlation is non-existent. So it's suggesting if you look just at CB1 expression for those receptors present in the brain, you think that they would be the same one for CB2. Not at all. So the individuals are very different. Moreover, when we look at the 78 cannabinoid responsive receptors, again, profiling the transcriptomic data of our own and the others, and basically making the total sum of the expression, and try to run the same correlation for these patients, and we found lack of it, right? So that basically means that even if you know what the main CB1 and CB2 receptors expression are, they're not even those that are responsive. A lot more of them are responsive, many of them are metabolized, whatnot, and again, unless you know the entire picture, so the individual transcriptome, you would not know what's the response, right? So what I mean, well, basically people all are different, so are all the cannabinoids and all the strains, right? So what we designed the algorithm where basically taking into consideration all the transcriptomes together with a microRNA, we can profile the state of the cell, a disease state, based on their transcriptome. And our idea is basically that we can not only predict what is the mark or signature, let's say, of the conditions that you have, but how do you reverse this process, right? How can you put this back to norm? And this reversal would be so-called cannabis efficacy score. So I will spare you with all this, but we have basically made the algorithm that allows you to profile extracts. So in this case, we've done UV-induced inflammation of 3D model of skin, right? And then, so after UV was applied in 24 hours, we did treatment with different extracts, and we identified, for example, one of them that was very efficient on returning, basically, roughly just, it's not correct, but let's say it returns 70% of all transcriptome back to norm. Versus if you take this one, it makes it worse, right? So cannabis is not the same, right? So we have recently done the same for two other tissues. So it's 3D oral tissues, 3D intestinal tissues. Here we induce the inflammation chemically by TNF, interleukins. And we also done the same, and we found some lines that's just amazing, right? So they almost entirely restore, so within 24 hours they restore transcriptome back to norm. So these all people are doing the work. I'm just here talking out for you, and obviously I was funded with different government and industrial sources. Thank you very much.